Good afternoon, everyone. Welcome back to AP Clash year 2022. So this is Kent So from Prince of Wales Hospital. Besides me is Dr. Simon Lam from Queen Mary Hospital. And we have a very distinguished group of panelists today to discuss further on a interventional perspective focusing on the mitral valve intervention. So let me introduce the panelists. So besides me is Dr. Eric Chen on live from Grantham Hospital. And we also have virtually, we have Dr. Shi Xiansheng from National Yongming Chiao Tung University from Taiwan. We also have Minoru Tabata, a famous cardiac surgeon on mitral valve from Japan. And also we have Dr. Yunlong Yo from Mount Hospital from Australia. And we also have prepared 3 very important topics on the mitral valve intervention. Thank you, Marvin. Thank you very much for the excellent talk. So, it's now open to discussion on the previous 2 excellent talks on different kinds of TMVR. So let me take the privilege to ask the first question to both Marvin and also Professor Lin. So in our locality, rheumatic heart disease is still prevalent. So there are, from time to time, we see patients that has mixed mitral valve disease due to chronic rheumatic heart disease. So if they are not operative candidates, I always think whether we should take these cohort of patients as a valve in MAC cases, or should we consider dedicated TMVR device? And is it actually feasible with the dedicated TMVR device? So any comment?
Ken, it's Marvin. So, I mean, I think it's a good question. The pathology of rheumatic disease is common arterial fusion, but one of the issues is sometimes it's characteristic for the valve to dome. So I don't know if sealing with a balloon expandable valve that has holes at the the ventricular side, where the cage is open, would properly seal. You may be able to anchor the valve, if you get lucky and you have good alignment, but I'm not so sure if you would seal with just a balloon expandable valve. Now, I have some experience with using the encircling dock of the M3 system for such cases. And in the 2 cases I've done, they were successful. So I think there is hope as long as your LVOT screening shows that you have an adequate neo LVOT.
I'd agree with that. I'd just add in one other piece that oftentimes in these patients, they have significant subvalve disease too. And I think that can be, particularly for the dedicated devices delivered transvenous transeptal, harder to deal with. We've had some early cases that unfortunately embolized up to the left atrium or malposed partially to the left atrium because of subvalve disease. Conversely, the transapical delivered device at Tendyne, because of its very nature, has had somewhat of a higher success rate anecdotally in small numbers of those types of patients. But there's certainly a spectrum of disease that we have to be careful about.
Thank you. So is there any other question from?
I have a question.
Yes, please, Dr. Song.
Thank you, Professor Lin, for a very nice talk. I just wonder, you have mentioned that for Carpentier type 2, maybe the TMVR could be the solution for complex anatomy. I just wonder, given what we have learned from the surgeon, that maybe mitral valve repair would be better than the mitral valve repair, but that is based on the cardiopulmonary bypass surgery, and after that, the heart may get some injury, something else. But given using the transcatheter valve TMVR, would you consider that it would be superior to the TEER procedure, given that we did not have data yet?
No, I would agree with you. I think there is data from our surgical colleagues that in Carpentier 2 disease, repair is definitely preferable over replacement. However, there's a subset of patients whose, due to its adverse anatomy, you can't do a repair option on them. And because of their extravalvular anatomy or issues, you can't do open surgery with bypass. And so in that subset, admittedly small slice of the pie subset of patients, we're exploring the use of TMVR.
Okay, thank you. Marvin, I just have a question about the valving ring, and thank you for your talk. The valving ring procedure, would it make difference to deploy a valve in a complete ring and comparing to the incomplete ring?
Yes, that's a great question. The complete rings are easier, or let's say it's more likely to be successful, with the caution or the caveat that small complete rings are problematic because usually the anterior posterior distance is small and your valves may not completely expand. So like I said, it just depends on what size ring. If you're looking at something in the high 20s, I think you've got a shot. If you're looking at like a 26 ring, then you look at it carefully on the CT. If it's a complete ring and you look at the area, it's very small, you may end up, if you do a valve and ring case using a 23 valve, and I think we've seen that 23 valves don't have great outcomes due to gradients. So it's an individualized choice based on the size and the area, and because even when you do much annulus repairs and you expect the annulus to be a certain size, sometimes it changes over time, or you get surprised by the dimensions of your annuloplasty ring in situ. There are a lot of examples where people have had annuloplasties, usually with incomplete rings or bands, where it's not what you expected. It's either the ring doesn't cover the commissures. I know you're asking about complete rings, but every once in a while I've been surprised by the anatomy of the annuloplasty ring.
Thank you.
So I have a question to Dr. Scott Lim, and because we know it's very promising for the TMVR, is emerging evidence and technology is advancing, but no matter how advanced, LV obstruction is still a genuine risk, and it doesn't appear that with advance in technology, this problem will go away. So that leads to a big issues of screen failure for our patient who really need that therapy. So do you see at this point, when the technology is further advancing, this could be addressed, maybe from a technology point of view, or the adjunct procedures that become standardized so that it could really solve the problem? And or shall we just at this stage still go back to master our skills in transcatheter HLS repair first, and to see in the future, probably now we have ways to remove the clip and put in the valve, but it's still a major long journey to go before we could go to that point. So can you give us some idea or what's your dreams in the future?
Sure, thank you for the question. And I do think that there's different ways technology can bear on the problem of development of neoil valve tract stenosis. And a good example is the CardioValve device. Their screen failure rate for neoil valve tract concerns for obstruction is only about 2 to 3%. So, and part of the reason is, even though that is a circular valve, sits in the annulus, if you look at it in profile, the LV alpha tract component of it is scalloped away from the LV alpha tract, and it has the anchoring mechanism that grabs the leaflet and pulls it toward the valve. So that's one option. Another technology is the C4 device AltaValve, which entirely sits up in the left atrium. It's a little bit of an odd design from that standpoint, but it definitely protects the LV alpha tract. So I think there's ways. And how I see this is, we're not going to find one valve that's going to work for all patients. We're going to ultimately need a toolbox, and depending on the anatomic or other concerns, we may choose a valve that has a much lower concern for LV alpha tract issues, or we choose another valve that has a greater radial strength because it's dealing with mitral annular calcification, or another valve because it's a sizing issue. So I see this as ultimately we need a toolbox of TMVR options, and I think we'll get there.
Maybe we also have questions from Eric and Baron. And
can I say a few things?
sure.
Thanks, Scott, and thanks, Marvin, for the excellent talks. From an Australian perspective, we've had some experience with mitral valve replacement device. At the moment, Tendyne hasn't started commercialization yet, but hopefully soon. We're waiting for the M3, but we've had some experience with the High Life, and they've got a Clarity valve which allows them to put it in patients which could get LVT obstruction, so they reduce the LVT sort of leniency and those allowances for those patients. But in terms of our backbone system, we're using, as most of Asia Pacific, the MitraClip device and then Pascal. But as you saw, most of the studies now, they're getting a lot of 1+ MR now following MitraClip and Pascal. In terms of where do you guys see, especially Scott, how we, especially when you've already got commercialization of your MitraClip in US, how do you fit in with the the mitral valve replacement devices when you've already got that reimbursement in place for the MitraClip?
Yeah, in the US geography I work in, that all the TMVR designs are currently under clinical trial. And so in terms of reimbursement goes, the Centers for Medicaid and Medicare Services, which determines reimbursement, has already adjudicated that as long as the patients are non-surgical, fit the clinical trial protocol, they're also not possible to do TEER, maybe because they've got mild MS or a very short retracted posterior leaf or something like that, then they will pay for it in the context of the clinical trial. Clearly, you in Europe are farther ahead of us in that there is, designs, particularly the Tendyne is the first out there, but others are going to be available sooner and have a greater commercial experience than we have here. I think just in a general sense, though, I agree with you. Because TEER has gotten so good, the safety profile is excellent, and now we're seeing, 1+ residual MR rates up to high 80 or even 90%, but that's the bar for patients that can get TEER. And that where TMVR is, for the most part, is either for patients that, due to their anatomy, complexity of the posterior leaflet or whatever else, that can't get TEER, or the open question still in my mind is the patients with functional MR. Is there a role for complete elimination of the MR? And is that a value over reduction in the MR? Because we're still, even with the best TEER, we're only seeing 20-25% elimination of the MR. But is that difference meaningful? That's a question we don't know.
And I would like to have a comment from Professor Tabata, because it's unfair because we're cardiologists and we're talking a lot on the new therapies, but don't forget we should not stretch our limit, because nowadays we have a lot of advanced and minimal invasive mitral surgeries. And can you have from surgical point of view, how do you see these battles or complementary issues and mitral repair, replacement, transcatheter and surgical? How could you comment on that?
Well, I'm an expert of surgical treatment. I also do TEL and TAVI, so I'm kind of hybrid surgeon. So I'm not anti-transcatheter person. So I think these all technologies are very useful because patients want more or less invasive procedures, and we also have many high-risk patients. We surgeons also are very much interested and want to be involved in these technologies. And actually, I have a quick comment from a surgeon's perspective regarding a valving ring. So since the valving ring, feasibility of valving ring and success rate differs a lot by ring size and rigidity and shape. So I think it would be great if you can bless the appropriate size ring, ring shape and size and type for surgeons. And it would be very great to discuss together about the appropriate repair strategy for future valve ring option to consider lifetime management of mitral valve disease. And can I ask a quick question, valve in valve? So we often use a very big valve especially for a functional MR, like a 31 or 33 millimeter valve. Is there still possible to do a valve in ring for such a big valve? If not, we should consider the valve size to consider the next option.
Any comment, Marvin?
Yeah, so I'm looking back at our kind of history of rings that I've done, and it's kind of variable, but it looks like 28, 29 millimeter rings work well, and they are semi-rigid, and if they're complete, those work the best for valve in ring, and then and as far as other strategies, like, whether there are extra cords, it hasn't seemed to make a difference. I can tell you, like, 34 is way too big. And then there's some rings that when they're small, like, but I don't know if anyone uses this anymore, like the Physio ring. When those were small, like, those ended up with high gradients and probably pinwheeling because of those valves, when they were implanted, that were non-circular because of the short AP distance. So, like, I think a good one was like a Medtronic Profile 3D ring. Well, actually, that wasn't the best, but maybe the St. Jude Rigid Straddle ring, or the Cosgrove Edwards Angioplasty, the Duran. They're actually, none of them are that great. Medtronic, I think the Medtronic Profile 3D ring was probably the best one that I thought we used. But they all have issues.
Yeah, I totally agree with you, Marvin, in terms of putting a circular valve inside of those larger rings. It's complicated. You're trading off, significant paravalvular length on either side. But with the dedicated TMVR designs, where you have a valve and then an outer stent frame that is more conformal to that, we've still had success with some of these larger rings. It gives us more options. I think I'm a little cautious of those incomplete, more Cosgrove type bands. They don't really give you enough of a landing zone. And I'm also cautious about those very D-shaped rings, so that your AP diameter is much smaller than your CC diameter. Those, you may risk more distortion issues of it. So it's clearly an art that we're learning. Early in the stage.
So what about the big tissue valve, like a 33 millimeter bioprosthetic valve? Is it?
Yeah, those are tough because because those tissue valve and valves, really right now the only valve we have that's working for that is the balloon expanded. And while outside the US there's a MyValve that goes bigger, you're still, when you're up in that range, it's people have limited access to it at present.
Yeah, I mean, it also depends if it's I think the porcine valves, even when they're that big, the inner diameter may be all right. It's like 29. So so it all comes back to the inner diameter. So because I know the pericardial valves, when they're that big, yes, then you have a problem if you use a balloon expandable valve. But the porcine valves tend to have like smaller inner diameters, like Epic, and you have, I think, more of an opportunity because of how much the sapien valve expands, that you could probably anchor it.
Thank you. Yeah, I think surgeons, need to get the knowledge to select the best option for patients. Thank you.
I have a question for all the panelists and speakers. Well, especially for Dr. Ng. When we put in a valve like a sapien in a valve in ring or valve in mag, you see a PVL which is intractable. So how soon are you comfortable with doing the PVL repair? What's the approach? Will transapical, like a hybrid approach, yield better results, like causing less embolization? Will you try to post-dilate, or will you put a new valve? What's your comfort zone, or what's your experience on that?
Yeah, so for rings, I've repaired without a lot of concern immediately, and typically you have to do it right away because sometimes the patients will hemolyze, and then if they get acute kidney injury, it just the patients tend not to do very well. For valve and MAC, I don't know if there's a good answer. Usually you do have to go. I still would prefer to repair it immediately, but there's some variability as to how well anchoring is, and I mean that's just the problem with valve and MAC. Right now there's a trial in the US called the Mitral 2. I'm sure you've heard of it, where we're looking at eligible candidates and also comparing them to people who are ineligible. And then, and this is just transeptal, valve and MAC with balloon expandable valves, and trying to see if there's a difference between an actual control cohort and the treated cohort. And so I think we still have, some questions about whether or not we can help people with MAC using balloon expandable valves. Like I said, I think ultimately we will have to use dedicated valves. And there's also the problem with LVOT obstruction screening because a lot of these people screen out. So I guess in summary, I'd rather repair immediately. Valve and ring, I'm not worried about. Valve and MAC, I have concerns, but so far I haven't caused an embolization from a PVL repair, but I'm sure someone out there has.
Thank you very much. I guess we all still have lots of questions, but because of the time constraint, I have to close this section. So to follow, we have around 15 minutes of break, and we'll welcome you back at 1:50, where we will have the opening ceremony. Thank you very much.